Okay, I want to apologize. We're running a couple minutes late. We had a little technical difficulty, but I'd like to welcome everyone in from our community today for being here for our lunchtime learning session around breast cancer. And so I'd like to do an introduction of Dr. Karen Smith. Thank you for coming back and doing a webinar for our community. Dr. Smith is an assistant professor of oncology at Johns Hopkins University School of Medicine. Her clinical practice is based at Sibley Memorial Hospital in Washington, D.C., and focuses on breast cancer care with an emphasis on young women. Her primary research areas of interest include patient-reported outcomes, reducing the toxicities of cancer therapies, improving care delivery and reproductive health issues in breast cancer patients. Dr. Smith is the director of Breast Medical Oncology at Sibley Memorial Hospital and co-director of the Young Women in Breast Cancer Program at the Kimmel Cancer Center at Johns Hopkins. She received a BA in anthropology at Washington University in St. Louis, and then attended medical school at Rush Medical College. She completed her internship and residency in internal medicine at the Hospital of the University of Pennsylvania, and then received an MPH at the Johns Hopkins Bloomberg School of Public Health, followed by a fellowship in medical oncology at Memorial Sloan Kettering Cancer Center in New York. Dr. Smith is here today to provide our community with some updates in advances in treatment for early stage breast cancers. So welcome, Dr. Smith. The floor is all yours.
Thank you so much, Jillian. Hello, everybody. I don't know if there are some new faces out there or if everyone is familiar, but I did give a similar presentation about a year ago. So today we'll be focusing on some updates with an emphasis on changes and developments that have happened within the past year or so. And I know that there is another webinar scheduled relatively soon through the iRise Above Foundation that will be focusing on updates in advanced breast cancer to kind of round out the 2022 updates. So I'm going to go ahead and get started. Please do let me know if there are any problems in terms of hearing me or seeing the slides. All right, so here's just a brief outline of today's talk. I'm going to give you a little bit of background so you have the terminology. We'll start just by defining the different subtypes of breast cancer and talking about staging so you understand exactly what I mean when I talk about early stage breast cancer. And then a little bit about kind of overall what are the general types of medical oncology treatments or systemic therapies that we use. And then we'll delve into the updates. We'll divide that up according to these subtypes. So we'll talk about triple negative, which is one of the subtypes, HER2 positive, another one of the main subtypes, and then hormone receptor positive, the final main subtype. So some of you, if you attended last time, may have heard some of this background information, but I think it's really important just that we are all on the same page in terms of the terminology. So I'll try to run through it quickly so we can get to the updates. So first off, what is hormone receptor positive breast cancer? So the vast majority, about 70+% of breast cancers are hormone receptor positive. And the way that's determined is on a biopsy sample that is stained in the laboratory to look for receptors for the female hormones, estrogen and progesterone. As long as there's any staining defined as 1% or more, it's considered positive. But in general, hormonal or actually anti-hormonal, also called endocrine therapies, are beneficial if the stain is greater than about 10% or so. So the next main subtype to think about is HER2 positive. This is also determined in a laboratory looking at a breast cancer biopsy specimen. And about 20% of breast cancers are HER2 positive. And it's actually pretty complicated testing. It can be done by two different types of tests now called immunohistochemistry or IHC or FISH, fluorescence in situ hybridization. And there's these complex kind of algorithms to define it. But basically, it's considered a positive test if it's 3+ or FISH positive. And again, that's about 20–25% of breast cancers. And triple negative breast cancer is kind of defined as the absence of these other markers. So it's estrogen receptor negative, progesterone receptor negative, and HER2 negative. So let's just briefly talk about staging. Today, we're going to focus on what's kind of referred to as early stage breast cancer. Staging describes the amount of cancer in someone's body, and it's important because it gives us some information about prognosis, so the expected outcome. It's often a really important component of eligibility for clinical trials, and it includes a lot of information about the cancer, so tumor size, lymph node involvement, whether or not it has spread to other distant parts in the body, the tumor grade, and the hormone receptor status, and the HER2 status. And then it's kind of divided into groups, 0, 1, 2, 3, and 4. Stages 1 and 2 are typically considered early stage, and then stage 3 is sometimes treated according to the same guidelines as early stage. So that's kind of what we'll be focusing on today, the stage 1 through 3. So here's kind of a list of the different types of medical oncology treatments that we use. So you're probably all very familiar with chemotherapy and endocrine therapy or hormonal therapies. Maybe a bit less familiar with some of our newer agents that are often targeted. So HER2 targeted therapies for HER2 positive breast cancers in general, cyclin-dependent kinase inhibitors, mTOR PARP inhibitors, and PIK3CA inhibitors. And then a new advance recently is immunotherapy. And then this kind of new class of drugs called antibody drug conjugates that we're going to talk about. So shown here in red are the types of therapies that we'll have some updates for today. Excuse me. So you can see that we have some updates really in a lot of different areas because there's been a huge amount of advances. And when you have your talk with Dr. with Dr. Stearns coming up, and she'll be reviewing advanced breast cancer, you're going to get even more updates with regard to many of these different types of treatments. So the final background piece of information is a bit of terminology regarding the timing of treatment for people with early stage breast cancer. So the word adjuvant therapy refers to treatment that is given after surgery, and the goal of that is to try to prevent the cancer from coming back or returning or developing into metastases. The term neoadjuvant systemic therapy refers to treatment that's given before surgery, and the goal of that is to shrink the tumor. You get some information about the likelihood of the cancer recurring, depending on how good a response you see. And that also gives you information about what type of therapy to give after surgery that will help decrease the chances of the cancer coming back. And finally, the term post-neoadjuvant systemic therapy refers to the treatment that is given after surgery to someone who previously had neoadjuvant treatment. All right, so a big update that we've had just recently are these new guidelines that came out from our professional organization, the American Society of Clinical Oncology, that basically looked at when we should be using neoadjuvant therapy. Historically, we were not using a whole lot of neoadjuvant therapy. Most of the time, people would have surgery first when they had a new diagnosis of early stage breast cancer, and then they would receive adjuvant treatment after their surgery. Now, as you can see kind of highlighted here, we're doing a lot more neoadjuvant therapy for patients with HER2 positive or triple negative breast cancers. And the key reason here is that we have really good therapies for them. And we've learned that depending on what we find after the neoadjuvant therapy at the time of surgery, we can get a lot of information about the prognosis, the expected outlook, and then we can adjust our therapy afterwards based on that information so we can personalize the treatment much more as opposed to kind of a one-size-fits-all type of approach. So this is a really big change that we've had just in the past year or two. So I'm going to kind of launch into some specifics then related to triple negative as it relates to that neoadjuvant treatment. So this slide kind of shows the general overview to how we approach triple negative early stage breast cancer. So shown on the top is small tumors that are called T1 that are node negative. So less than 2 centimeters and node negative. We usually do surgery first, and then we most often will do chemotherapy in the adjuvant setting afterwards. Shown on the bottom is the more recent approach that applies to tumors that are larger than 2 centimeters or that have spread to the armpit lymph glands. And in that case scenario, we do neoadjuvant therapy. We do the systemic treatment first, and then we do surgery. And then depending on what we find at surgery, we decide about further post-neoadjuvant therapy. So the big study that many of you may have heard about in this realm is called KEYNOTE 522, and it's looking at immunotherapy plus chemotherapy in this situation, so neoadjuvant and post-neoadjuvant for early stage triple negative breast cancer. So let's just kind of pause and make sure everyone knows in general what immunotherapy is. This is a whole new class of drugs that really only entered the breast cancer world in the past few years. But basically, your immune system is involved in the reaction to cancer. And if we can pump up the immune system, we can kind of get the body to fight against the cancer itself. And so there's different types of immune therapies. They target specific antigens that are located on the outside of either immune cells, PD-1, or cancer cells, PD-L1. And there are a number of different agents, but in general, if you give one of these agents, it revs up the immune system, a particular part of it called the T cells, and that leads to the body attacking the cancer itself. So we are now doing more chemo and adding immunotherapy in the neoadjuvant setting for triple negative breast cancer. So why is this a good idea is the first question. The issue here is that we realized that if we give more treatment before surgery, the cancer is more likely to be all gone at the time of surgery, and that's called a pathologic complete response. And we know that the less cancer that we find at the time of surgery, so if we give chemo and immunotherapy first, and then we do surgery and we look under the microscope and we see no cancer or just a tiny bit of cancer, that indicates a very low risk of recurrence. And so we want to do everything we can to achieve that goal of having no cancer, that pathologic complete response, or just a little bit of cancer left behind. The other thing is if we find cancer there, we have the information that we know we need to do additional treatments. And for example, a drug called capecitabine can be given there. The graph that you see on the right looks at the likelihood of the cancer coming back according to how much cancer is found at the time of surgery. So shown in the blue line at the top are the group of patients for whom no cancer was found at the time of surgery. And you can see that the likelihood of the cancer staying away is almost 100%. That's why it's just a straight line at the top, whereas at the bottom, shown in red, are the people who had a fair amount of cancer left behind. And you can see that the likelihood of the cancer staying away is only about 30%. So it's a big difference according to how much cancer we do find at the time of surgery. So in the KEYNOTE 522 study, patients who had stage 2 or 3 triple negative breast cancer were treated with chemotherapy with carboplatin and paclitaxel, followed by an anthracycline and cyclophosphamide, so a fairly standard chemotherapy regimen, plus either a placebo, which is just a salt water infusion, or pembrolizumab, which is one of those immunotherapies. And then they had surgery. And then the people who were getting the pembrolizumab actually continued it in the post-neoadjuvant or adjuvant setting. And the people who were getting the placebo just continued that. There were 2 main goals of the study. The first one was to figure out what's the likelihood of the cancer being all gone at the time of surgery, and that's called the PCR rate. And the second one was to look into the future a few years and say, what's the likelihood of the cancer coming back? And that's called the event-free survival. So on the left, you can see the PCR rates, and the blue shows the pembrolizumab arm. So about 2/3 of patients in the pembrolizumab arm had no cancer left. And that was much more than in the chemotherapy alone arm, which was about 50%. So definite improvement in the PCR rates with the addition of pembrolizumab. Shown on the right, it looks at different groups of patients to say, does everybody benefit from the pembrolizumab, or is it maybe just some types of cancers or certain types of patients? The fact that all of those lines are kind of on the right of the vertical dotted line suggests that the benefit is seen really in everybody, that we're not able to identify a specific group of patients in whom the pembrolizumab could be omitted. And it did seem, however, that it was greatest in people whose axillary or armpit lymph nodes were involved. The other important thing here in this picture on the right is that there's this test that can be done on the tumor called PD-L1. And they found that in this study, it didn't matter if the tumor had PD-L1 or not, there was still benefit from pembrolizumab. This is a little bit different from when we use pembrolizumab for metastatic breast cancer, because in that situation, it only works if PD-L1 is expressed on the tumor, but it doesn't seem to matter when we use it in this situation. So what's happened most recently is we got that longer term follow-up data, which is called the event-free survival. And so you can see on the left, the orange line is for the pembrolizumab plus chemotherapy arm. And in the blue, it's the placebo or saltwater infusion plus chemotherapy. And you can see that they're very different and that the orange one is higher. And it's suggesting that the likelihood of the cancer returning is lower. So after about 3 years, 84.5% of patients who got pembrolizumab did not have return of the cancer. In comparison, about 77% in the placebo arm did not have return of the cancer. So there was about a 10 or 8 to 10% benefit, which is a pretty meaningful difference. When the cancer did come back, it was most likely that it came back in another part of the body as opposed to in the area of the breast or the close by lymph glands. So this is another one of those graphs kind of looking at whether or not the benefits of pembrolizumab apply to everyone. And the fact that pretty much all those lines are on the left side shows again that everybody seems to benefit in terms of preventing the cancer from returning over time. And again, the PD-L1 didn't make a difference. Everybody benefited regardless of if they had that on their tumor cells. So the big issue with anytime we add therapy is that we sometimes add toxicity or side effects. And so we always have to kind of balance out, does it make sense to do all of this extra treatment, or is it not worth it because of the downsides? And one of the big issues with pembrolizumab or immunotherapy is that since it's revving up the body's immune system, it can cause these unusual side effects that are related to the immune system getting hyperactivated. So it can lead to thyroid disease or problems with your adrenal glands, which are glands on top of your kidneys, or inflammation really in any different part of the body, but especially a place like the lung or the pituitary gland in the brain. What they found, though, that overall, the immune-related side effects didn't seem to be such a huge problem. They mostly occurred at the beginning, before the surgery. And they overall, I think for most patients, the potential benefits of the regimen kind of outweighed these toxicities, but it does require some pretty close monitoring and being careful in case these things happen. So what they did also more recently is they did kind of an extra analysis. They were trying to sort out this issue of, do we actually need to do the immunotherapy after surgery? Because in the study, if you remember, people got immunotherapy and chemotherapy together and then surgery, and then they got more immunotherapy. And the question is, do you really need that? What if the cancer was all gone at the time of surgery? Can you just stop? Because it's another, many months of therapy and many more months of potential risk for toxicities. So they looked at the people who had no cancer left at the time of surgery, which is the PCR group shown on the left, and looked also at the people who had cancer left at the time of surgery, who did not have a PCR, shown on the right. And so you can see that for both arms, the pembrolizumab arm and the placebo arm, the likelihood of the cancer coming back in the setting of a pathologic complete response is really low, 5%, 7%. Whereas on the right, the likelihood of the cancer coming back, if you did not have a pathologic complete response, if there was still cancer there at the time of surgery, is much higher in both arms, 30%, 40%. So that tells us that we still have work to do for people who don't have a pathologic complete response, and that we definitely don't need to do additional treatments after surgery. But it does make us kind of wonder, for the people who are fortunate enough to have no cancer left at the time of surgery, that maybe it's okay to stop treatment at that point and then thereby reduce toxicities. It's not yet been proven research-wise, and I think some additional studies are needed, but it's certainly something to kind of talk about with your doctor and think about if that's an option for you. So I'm going to switch gears. I'm going to move on to HER2 positive breast cancer. So this is the other subtype that we talked about that is defined as a IHC score of 3+ and or being FISH positive. This refers to about 20% or so of breast cancers. And this is a particularly aggressive form of breast cancer, but ever since we developed these really effective anti-HER2 therapies, it's become very successfully treated. And it's one of the best types of breast cancers to get if you have to get breast cancer, because our treatments have become phenomenal. I actually don't have a lot of updates for HER2 positive breast cancer because the established treatments are really quite effective, actually. So I'm just going to share one study that was recently presented just so you have a sort of a comprehensive update. And that's the TBCRC 033 study. So let's just start by kind of looking at that algorithm, that kind of overall approach for HER2 positive disease. So you kind of know where this study fits in. So on the top row, this is kind of like for the triple negative. For the smaller tumors that are node negative, excuse me, so the T1 N0, we typically do surgery first, and then we will consider doing therapy, chemotherapy and or HER2 therapy in the adjuvant setting. On the bottom, it's the same kind of deal as we saw with the triple negative. For the larger tumors, 2 centimeters or larger, that are potentially node positive, we do neoadjuvant therapy and then surgery, and then we look and we see, is there residual disease or not? If there is residual disease, we will continue HER2 targeted therapy with 2 drugs, trastuzumab and pertuzumab. I'm sorry, if there's no residual disease. If there is residual disease, we will switch to a drug called TDM1. So the update that I want to share refers to TDM1. And TDM1 is one of these really exciting new classes of drugs. It's called an antibody drug conjugate. And what that is it's an antibody, trastuzumab, which is goes against the HER2. And it's joined with a linker to what's called a payload, which is a chemotherapy drug. And in this case, it's imtansine. And what it does is the antibody goes to the cell that has the HER2 expressed on it, and then it kind of dumps the chemotherapy there for it to do its job. So it's very targeted therapy. And there are now a number of different antibody drug conjugates that are either approved or under development for different types of breast cancer. And when you hear the metastatic update, you'll hear in particular about another HER2 targeting antibody drug conjugate that's been very, very successful, but not applicable to the early stage setting. So I'm just going to go back a second. Typically, we use TDM1 in the setting of residual disease after neoadjuvant therapy. But the question has arisen whether we should use it in earlier stage disease in people who have surgery first and then need adjuvant therapy. Typically, we have done chemotherapy with paclitaxel and trastuzumab, that HER2 antibody then. Question is, would TDM1 be an option in that situation instead? And that's what the TBCRC 033 study looked at. So it compared trastuzumab plus paclitaxel to TDM1, and it had 2 main goals. The first one was to kind of look at the toxicities and see if they were different, because sometimes we make a choice based on side effects, and we want if 2 drugs are equally, or 2 regimens are equally effective, we want to pick the one that has the fewest side effects or that might be most preferable on an individual basis. And then the second one was to just say, well, let's just check out this TDM1 arm a little bit more and make sure that it looks like the likelihood of the cancer coming back is really nice and low with it. So that's what you see here on the right-hand side. You see the recurrence outcomes for TDM1. The fact that those blue lines in the top 2 are way up at 100% basically tells us that over time, over more than 5 years of follow-up, the probability of the cancer returning is of close to 0. So the probability of it staying away was almost 100%. It was in the 97, 98, 99% range, which is really, really good. So that tells us that the TDM1 appears to be very effective in this setting. Shown on the bottom, they're kind of looking at the differences in the effectiveness in the TDM1 according to the tumor size, if it's smaller than or larger than 1 centimeters, and according to whether or not it's also hormone receptor positive or hormone receptor negative. And again, you can see very minimal differences there, suggesting that it is effective really for anyone in this particular case scenario. So for small node negative tumors after surgery. In terms of quality of life and side effects, they found that overall, the likelihood of sort of really important side effects that were troublesome to people was not different. So approximately the same number of patients in both arms of the study had troubling side effects. But what they found interestingly is that the specific side effects were different. So with the TDM1, we saw more problems with blood tests related to low platelets and one of the liver enzyme blood tests called bilirubin. Whereas with the paclitaxel and trastuzumab, we saw more problems with hair loss, numbness and tingling in the fingers and toes, low white blood cell counts, stomach problems like diarrhea or reflux, and then kind of like an allergic reaction. Shown in the right is the quality of life data. And you can see that for the trastuzumab, it kind of dipped down right at the beginning, and that was during the chemotherapy portion because that Taxol part is given for the first 3 months, and then it's just trastuzumab alone. So it came right back up and was generally similar to the blue line for the TDM1 for the rest of the time. Shown on the bottom is the proportion of patients participating in the study who had hair loss. And on the top row of circles is the TDM1. So you can see that really it was probably around 5 to 15% throughout the entire course of therapy. Whereas on the bottom row, it's the paclitaxel and trastuzumab. And you can see that at 3 weeks and 12 weeks, a good number shown in red had hair loss, which is not surprising because we were giving chemotherapy and that then generally it grows back. So I think really the conclusion from this particular study is that TDM1 is an option in this setting, but that the decision between these two drugs, I think paclitaxel trastuzumab is probably more an established treatment, but the decision of which one to use can actually be personalized and largely based on side effects. There's kind of pros and cons to each. So this is just another opportunity where we sort of have more choices, and it's always good to have more options, kind of more tricks available. So I'm going to move on to the last subtype, and this is actually where I have the most updates. This is hormone receptor positive breast cancer. So remember, this is breast cancer that expresses receptors for the female hormones estrogen and or progesterone. And I'm going to talk about 4 main topics. The first one is what we call adjuvant cyclin-dependent kinase inhibitors, and those are the PALLAS and MonarchE studies. I'm going to talk a little bit about genomic profiling to guide decisions about whether or not to give chemotherapy for hormone receptor positive, node positive breast cancer. That's called the RxPonder study. I'm going to give a little bit of an update on hormonal or endocrine therapy for young women. We've had some very important studies that have been done over the years, and we've got some longer term follow-up recently about those. And finally, I just want to touch on a new topic that we have a little bit of data looking at what's called ctDNA, a measure of minimal residual disease that relates specifically to hormone receptor positive breast cancer in the late adjuvant setting, sort of many years after diagnosis. ctDNA is being studied in other types of breast cancer and at other times also, but I'll just share an update that's pretty interesting and recently published specifically related to hormone receptor positive breast cancer several years after diagnosis. So let's get started. We'll start with the cyclin-dependent kinase inhibitors. There are 3 of these. They're all approved: palbociclib, ribociclib, and abemaciclib, and they block the cell cycle. Cells are kind of going through this cycle, dividing and growing and dividing and growing. And in metastatic breast cancer, they slow the progression when they're given in combination with hormonal therapy, and they improve survival. So whenever we get a really great drug that works in metastatic breast cancer, we always say, well, what if we give it to people who have early stage breast cancer? Will it help prevent metastases from happening? And so 2 recent studies have been published looking at CDK4/6 inhibitors in the adjuvant setting, so after surgery. So the first one is the PALLAS study. This was for people with hormone receptor positive stage 2 or 3 breast cancer, and they were randomized, and half of them got palbociclib for 2 years plus their hormonal therapy, and the other half got their hormonal therapy alone. And the goal was to look for recurrence, measured as something called invasive disease-free survival. And you can see on the left the overall efficacy data. And it's kind of hard to see because it's a little bit small, but there are blue lines, which refer to the palbociclib plus the hormonal therapy. And there are red lines, which refer to the hormonal therapy alone. The reason it's actually a little hard to see is that the lines are basically on top of one another, meaning that there was no difference. So taking the palbociclib did not reduce the chances of the cancer coming back. The fact that all of those lines are very close to the top again indicates that, at least with the amount of follow-up that there is thus far, which is a few years, about the average follow-up is about 2.5 to 3 years, there have not been a lot of women who've experienced a recurrence. So the vast majority have been cancer-free, but there does not appear to be a difference based on whether or not they took palbociclib. On the right is another one of those pictures to try to look at different groups of patients who participated in the study and to say, well, maybe were there some of them who benefited from the palbo, even though overall people didn't seem to benefit. And you can see that really nobody seemed to benefit because all of those lines cross that vertical dotted line going down the middle. So it doesn't seem that it helps, even though it does help control the cancer when it's given in metastatic breast cancer. The most common side effects were low blood cell counts and fatigue, which is not surprising. So everyone was very disappointed about this study, but we found out about a very similar study with different results, and this is called the MonarchE study. This is looking at a different CDK4/6 inhibitor called Abemaciclib. It had similar eligibility criteria, meaning the groups of women who were eligible to participate in the study were fairly similar. So they had hormone receptor positive breast cancer, and they'd had their chemo if they were going to get it, or their surgery, and they were getting started on their hormonal therapy. There was a little bit of a difference though. They only accepted women for participation if they had a higher chance of the cancer coming back than the women who were allowed to participate in the PALLAS study. So for this study, the way they measured that is based on how big the tumor was, how many lymph glands were involved, or the way it kind of looked under the microscope. So it was for people who had at least 4 armpit lymph glands involved. Or if they had only 1 to 3 armpit lymph glands involved, they had to have a tumor that was larger than 5 centimeters, or a high-grade cancer, or evidence of cell proliferation and growth that was pretty quick, as measured by this test called Ki-67. And so this was a higher risk group than participated in the PALLAS study. They either got their hormone therapy by itself or the Abemaciclib for 2 years plus their hormone therapy. And you can see shown on the right at the top the efficacy data, and those 2 lines are separate. Fortunately, they're both kind of close to the top, but they definitely are separating out. And you can see that after 3 years, the likelihood of recurrence was different between the 2 arms. It was 88, or the likelihood of being cancer-free was 88.8% with the Abemaciclib versus 83.4% without it. So about a 5% difference. And this will be followed for even longer, and further differences may emerge over time. The benefit was seen even for patients with low Ki-67, but the thinking is that if that Ki-67 marker is higher, it may identify patients at higher risk of recurrence. And so the way that this drug has ultimately been approved includes that Ki-67 test. So the question is, what do we do with this data? I think that this is a new standard of care for patients who meet these kind of criteria, that they have node positive, high Ki-67 disease, or other high-risk features. There are some caveats. The follow-up is not all that long. We actually don't know, they didn't get a CAT scan or a PET scan, so we don't know if any of the patients actually already had metastatic breast cancer, but we presume that they didn't and that this drug helped to prevent it. And we're not really sure why it differed from the PALLAS study. It might be that the patients were different. As I said, this might have been a higher risk group population. It might be that one of the drugs is better than the other, or it might be that the way the drugs are dosed is a bit different, or it might be that we haven't done the same amount of follow-up. We have slightly longer follow-up for the PALLAS study. The other caveat is that it's not without toxicity. The biggest problem is diarrhea, and some people also really struggle with fatigue. And about almost 20% of patients actually stopped it because of side effects and toxicities. So it's definitely something to consider. And I've been using it in my patients. I'm strongly in favor of it, but it is something to consider carefully. And you have to stay on top of the toxicity. There's really good treatments, especially for the diarrhea, but it is something that requires attention and has to be closely monitored and acted upon quickly if it happens. Fortunately, the diarrhea often goes away after just a few months. It doesn't tend to last or to be as severe for the whole 2 years. Okay, so we're going to move on now to chemotherapy. Many of you may be familiar with a test called Oncotype Dx. It's been around for many, many years now. It looks at multiple genes, about 21 genes in a cancer specimen. Scores range from 0 to 100, and we know that higher scores indicate a higher risk of cancer return. So it gives prognostic information for hormone-sensitive early-stage breast cancers. There was a study a number of years ago now called the TAILORx study in node-negative breast cancer patients, where they randomized people with kind of middle range scores to chemotherapy or not. The thinking was that if you had a low score, you definitely don't need chemotherapy. And if you have a high score, you probably do need chemotherapy plus hormone therapy. But there was this big question of people in the middle. Do we need chemotherapy? Where's the cut point? And this basically showed that for people with a score of less than 26, overall endocrine therapy alone is not inferior. So you can leave out chemotherapy. There's no difference because in that top there and the bottom there, you can see the lines are basically on top of each other. But there was a little caveat that's been published in the past few years that some of you may be aware of. The issue was in younger women. And when you took kind of a deeper dive into the data, it looked like maybe there was a little bit of benefit from chemotherapy starting to emerge for women under 50 who are generally premenopausal and having monthly cycles if their scores were 16 to 25. So nobody really knows. Is that because they need chemo? Is it because their cancers are more aggressive and they definitely need chemo? Or is it that the way chemo might be working in these patients is that not only does it kill any renegade cancer cells, but it also harms the ovaries. And some of you may be aware that chemo itself can bring on menopause. And if that's the case, could we just skip chemotherapy and bring on menopause? And that's kind of an unanswered question. The reason I bring this up, even though it's slightly older data, is that now we have a similar study that was just published in the past year or so, looking at the same question in node-positive disease, and the same issue ultimately arose with regard to premenopausal women. So this is the RxPonder study, and it was for people who had 1 to 3 armpit lymph glands involved with cancer that's hormone receptor positive, and they've had their surgery. And then we checked their oncotype. If their score was over 25, the recommendation was to do chemotherapy and hormonal therapy, not participate in the study. But if their score was between 0 and 25, they were randomized by the flip of a coin to either chemo, then endocrine therapy, hormonal therapy, or just to the hormonal therapy. About 2/3 of the patients were postmenopausal. Those women typically got docetaxel and cyclophosphamide chemotherapy if they were given it, and the premenopausal people typically got an anthracycline and taxane-based chemotherapy. And importantly, very few of the younger women had induction of menopause by ovarian suppression. So these are the key results. It's actually a really complicated study to interpret. But basically, overall, the adding chemotherapy did not help in general. But kind of like in the other study, there was an interaction between whether or not chemo helped and menopause status, meaning that the effect of chemo varied for premenopausal women and postmenopausal women. So for the older postmenopausal women, absolutely, chemo did not help. So we can very comfortably say that an older woman over 50 who's postmenopausal, who has a score under 26, does not need chemotherapy. But kind of like in the initial study, the TAILORx study in premenopausal women, the addition of chemotherapy did seem to be helpful. We couldn't really find a cutoff score that said whether or when it was safe to definitely omit chemotherapy. But again, we don't know if it's the chemo that helps or if they just need induction of menopause. And so this gives some of those more specific numbers for the postmenopausal women. For endocrine therapy and chemo, the likelihood of staying disease-free 5 years into the future was 91.3% versus 91.9%, essentially the same with hormonal therapy. Whereas in the bottom row, there's a difference. It's about 94% for chemo plus hormonal therapy versus 89%. So about a 5% difference for the addition of chemotherapy for the younger women. So again, this was very practice changing in that it told us we can definitely omit chemotherapy in postmenopausal women if they meet these criteria. But for premenopausal women, we're still not sure. And this is an area of a lot of debate. Some people feel that, you know what, you just have to give chemotherapy because we can't for sure say that you don't need it. Other people really feel that, you know what, I'm sure the reason chemo is helping is that it's inducing menopause. And we, as I'm about to tell you, are really quite good at inducing menopause as part of our hormonal therapy. So ultimately, I think this is going to require another big study to answer it. It's a really gray area right now that we don't have a clear-cut guideline. So let's get into the hormonal therapy. We're almost done going through our updates. So these are the list of options for premenopausal women. Tamoxifen followed by an aromatase inhibitor if a woman reaches menopause, or ovarian suppression or ablation. And that's the fancy name for inducing or bringing on menopause, plus tamoxifen, or inducing menopause plus an aromatase inhibitor. There were these really big studies a few years ago called the soft and text studies that kind of looked at all of these different options. And we got some updates recently. So these are the original data published in 2018, and they basically said that the lines are pretty close, but there are some differences. And they basically said that inducing menopause is better in terms of preventing the cancer from returning, especially if it's done with an aromatase inhibitor over tamoxifen. But we most recently got a 13-year follow-up. And that's really, really long. But the thing about hormone receptor positive breast cancer is that unfortunately it can come back really late, many years after diagnosis. So it's actually super important for all of these studies to follow the women who are generous enough to participate for many years, so that we can get some updates and make sure that our original findings that we publish actually stay true. So we learned at our San Antonio meeting this past December in 2021, the 13-year follow-up data, and basically the likelihood of recurrence as measured by the disease-free survival was lower with the aromatase inhibitor and the induction of menopause compared to tamoxifen and the induction of menopause, about a 5% difference. In this study, they were starting to see a suggestion that there might even be an overall survival benefit, so that the odds of overall beating breast cancer might be even better with the use of the aromatase inhibitor. However, that is not yet statistically significant, and it's limited to particularly high-risk cancers. And the other thing that we got is that what's called a meta-analysis, and that's when you take data from several different studies. So they did the soft and the text studies and 2 other ones. And these were all studies looking at ovarian suppression and whether it should be done with tamoxifen or an aromatase inhibitor. And you kind of clump it all together and do one analysis. And sometimes because you have so much more data from so many more women, you're able to discern differences between the treatment options that can't necessarily be identified in the individual studies. So this looked at data from over 7,000 women with a median follow-up of 8 years, looking at the induction of menopause and whether it should be done with an aromatase inhibitor or tamoxifen. And you can see that those lines on the top in terms of recurrence are different. The red lines denote tamoxifen and the blue lines denote the aromatase inhibitor. And overall, the recurrence rates with tamoxifen plus the ovarian suppression were higher than with the aromatase inhibitor shown in blue. But on the bottom is looking at the odds of overall surviving and beating the breast cancer, and there's no difference yet. We may find more as we follow for longer. The other caveat with all of this is toxicity. Just like we have to make decisions about treatments based on toxicities with HER2 positive cancers and triple negative cancers like we already talked about, when we induce menopause, and in particular when we give an aromatase inhibitor, we harm the bones. So we can bring on osteoporosis, which can predispose to fractures. There are certainly other symptoms also associated, but that was one that was definitely picked up on this 7,000% analysis. So I think we're on to the very last topic, and this is the ctDNA topic. So I want to just go back a little bit to that issue of late recurrence. So the different subtypes of breast cancer, the HER2 positive and the triple negative and the hormone receptor positive, they have very different patterns. For the HER2 positive and the triple negative breast cancer, if the cancer doesn't come back within the first few years after diagnosis, the chances of it coming back are very, very low. So that's a huge relief to many women once they get out of that first few year time period of follow-up. For hormone receptor positive breast cancer, the risk pattern over time is very different. It tends to be lower throughout the course of time, but it tends to just be kind of continuous, and it doesn't go away after just a few years. So if you look over many, many years and you kind of add up overall the likelihood of recurrence, you can see that it kind of keeps on adding up over time. So this here shows out to 20 years, and you can see the risks just kind of keep on going up with time. It's not that it is actually higher in one year than the next. It's actually the same every single year, but over time you just get more and more women who ultimately will have a recurrence. Fortunately, that risk is largely based on the level of risk at diagnosis, which is based on things like how many lymph glands were involved and things like that. And so for Women who have more lymph glands involved, so shown in the red, the recurrence risks over 20 years are much higher than those who have no lymph glands, shown in the blue on the bottom. But about half of the recurrences occur in the first 5 years, and about half of them occur over the next 5+ years. So because of this, we have been looking at extending therapy. I believe last year I talked about looking at doing 5 to 10 years of hormonal therapy. And then we've also been looking at what other things we can do, things like the Abemaciclib, other things that we can do to escalate the therapy. A really big issue here is, again, toxicity and wanting to better individualize the treatment. There are, unfortunately, lots and lots and lots of women who have a history of early stage breast cancer. And fortunately, the vast majority of those women will never have a recurrence. What we want to be able to do is better identify who's really at risk for recurrence. And then we can identify and target those individual women with the right kinds of treatments, as opposed to taking a really blanket approach of treating everybody, because then we end up giving lots and lots of people treatment that they may never need and that has a whole lot of side effects. So there's a lot of research going on right now to try to look at blood tests or other types of tests that may help us better identify the risk of recurrence. And I'm presenting this to you just because it's research, not because I think you should get this test as a part of standard of care yet, because I think we are still learning, but I think it's really important to understand, and I think it's the wave of the future and kind of where our care is ultimately going. But there's this concept now called minimal residual disease, and it's exactly what it means. It means, like, what if there's just a tiny little bit of cancer left in the body? You wouldn't necessarily see it on scans, but maybe it's hiding somewhere, but you might be able to detect it on super fancy blood tests. And there are a whole bunch of these super fancy blood tests under development. Some of them are looking at tumor cells that might make their way into the bloodstream, CTCs, or circulating tumor cells. Some of them are looking at little fragments of tumor genomic or genetic material called circulating tumor DNA. What they have found is that in patients who have these things detected in their blood, over time, the likelihood of the cancer returning is higher than for patients who do not have these markers detected in the blood. So you can see on the left a test or a study that was done in patients with the circulating tumor cells detected, and on the right, a study that was done in patients with the circulating tumor DNA that was detected. And the recurrence-free survival was very different. You can see that those lines in each of the graphs are very far apart. So the challenge for us is to figure out, how can we use these tests, and then what do we do if we can find somebody who has this particular blood test? What treatment should we give? Can we make it go away? And therefore, can we make the cancer not come back? And that's a really big area of research. What recently happened, and this was presented at our big ASCO meeting and then published in our main journal, the Journal of Clinical Oncology, just within the past month, was they looked at this issue of minimal residual disease using ctDNA in hormone receptor positive breast cancer in the late adjuvant setting. So people who had breast cancer several years ago, and they had stage 2 or 3 breast cancer, and they analyzed their initial tumor biopsy to make a personalized ctDNA blood test. And then they drew their blood over time. And they were trying really just to sort out, how likely are we in this group of patients to detect the ctDNA? Because nobody even knows. These tests are so fancy and so new that nobody even knows whether lots of people have it in their blood or not. And so that's really the first step before we can even move on and kind of start to do anything about it. So this was a really exciting study. They ultimately tested 83 patients, and they followed them over time. On the left, you can see those recurrence patterns, and they were different once again. So people who had the ctDNA detected are shown in red. They had a much higher chance of the cancer coming back than people without the ctDNA detected, shown in blue. Overall, about 10% of patients had ctDNA detected. And everybody in whom the cancer came back had the ctDNA detected. It was about a year between time of detection and time of recurrence. There's a lot of unanswered questions. We don't know if they actually already had scan detectable disease at the time that it was detected, because nobody got a scan right at the same time as their blood test. And we don't yet know what to do with this. If we find it, what treatment should we initiate? Can we make it go away? And then if so, does that mean that the cancer doesn't come back? So this is a step towards the future. It's not a test that I think you need to have right now, but I want you to be assured that this is a huge area of research and we're really excited about it. I'm going to close out 2 really important negative studies with 1 word each, just because people may ask. There was a lot of hype about some potential additional drugs that might reduce recurrence, and these are drugs that are used for other purposes, aspirin and metformin. And these ultimately led to very large randomized studies where some people got the drug and some people didn't. And they were both negative studies. This is really disappointing because I think everybody was hoping that these would help reduce recurrence. But it tells us this is why we do studies and why we don't necessarily just believe early research or anecdotal research and give a lot of treatments without the data. This is really important because these drugs have side effects. And so we now know that they're not something that we should be giving. So in conclusion, I think we're doing great. We are moving the needle forward. We've had so many updates, and you'll hear more about advanced breast cancer from Dr. Stearns soon. Excuse me. But we've had early stage updates that span all of the subtypes. Just a final word about that ctDNA. I think it's super exciting. It may help us figure out who to give treatments to and who's at the highest risk, but it's not yet ready for use. Its clinical utility is not yet ready, not yet determined. And overall, my take-home message is I think really treatment needs to be personalized. There's pros and cons to everything that we do. And we don't want to give over treatment, and we don't want to give under treatment, and we don't want to give treatments that are overly toxic or, toxic to one specific individual based on certain health characteristics that she may have. So it really needs to be individualized. It's not one size fits all. And we now have lots of options. So we are fortunate to be able to do that. I'm going to stop there as a whirlwind. It looks like there is one question I can take, and then Jillian, I don't know if you want to do anything else.
Sure. Are you able to answer and read the question?
Yes. So The question is, can a person stand tamoxifen even after menopause was reached? The answer is yes. Tamoxifen works for premenopausal women and postmenopausal women. The aromatase inhibitors only work for postmenopausal women, or for premenopausal women in whom we induce menopause. But so if we are uncertain about menopause status, we either induce it or we put a woman on tamoxifen. So I'm happy to take any other questions. Or to close out, it's 12:57. Jillian, it's up to you.
Yeah, is there any, this is always super informative. I always look forward to these talks, and I think back to 10 years ago, how much has changed, how much has advanced, and it really gives me hope for the future. And so that, my community is able to live a long, enjoyable life. So this is all really great advances. So thank you for sharing that with us today. Is there any more questions from the audience? No? Okay.
We just got to thank you.
Yeah. Wonderful. Well, thank you again. I really appreciate you taking the time again, Dr. Smith. This has been really, really wonderful. And I will share this recording with our community sometime this week for sure. Thank you so much.
Take care. Have a good day, everybody. Thank you.